Welcome to my lecture about abnormal stature in children for NAC OSCE. Dr. Mohammed Abdul Manam, Starmed Medical Education Programs, www.medcanada.com, June 22nd, 2022. The diagnostic criteria for short stature height is less than the third percentile, or gross velocity is less 4 centimeters per year, but the normal should be 5 centimeters per year. However, tall stature height is greater than 97 percentile. History, we should ask about the name, the age, the gender, ethnicity, and home. Of course, the chief complaint will be abnormal stature, short or tall. History of present illness. We have to ask general questions such as the growth pattern, sexual maturity, nutritional status. For the short stature, we have to differentiate non-endocrine causes and endocrine causes. In the non-endocrine, such as chronic illness, the weight will be low. On the other side, endocrine causes such as growth hormone deficiency, the weight will be high for the height. On the other hand, tall stature, there is causes such as hyperthyroidism, precocious puberty, obesity, and dysmorphic features such as Klinefelter. Red flags here, we have to ask or see if there is any dysmorphic feature, gross velocity less than 5 centimeters per year, precocious puberty in male, delayed puberty anuria in female, and neurological symptoms, and finally pathological fracture, which can be seen in osteogenesis imperfecta. Past medical history, we have to ask about any chronic illness such as endocrine, asthma, cancer, and we have to ask about pregnancy and birth history such as birth weight, oligohydramnios, torch infection, etc. In the past surgical history, we have to ask about neuro or cardiovascular surgery. Medication, you have to ask about corticosteroid or chemotherapy. We have also to ask about allergy for any medication or food or any environmental cause. In the immunization and vaccination, we have to ask if it's up to date or not, because it will give us an idea if the child neglect or not. In the social, we have to ask about alcohol, smoking, recreational drugs in the family. Also, family history, we have to ask about any sibling, grandparents, any relatives who had the same concern or condition. Also, genetic syndromes, also cancer, Cushing, growth hormone deficiency, and hypothyroidism. Review of system, neuro, we have to ask about the neuro symptoms such as visual change, headache. MSK, ask about fractures, respiratory symptoms, wheeze, cough, GI, vomiting, diarrhea, constipation. GU, we have to ask about hematuria, polyuria, and the risk factors, we have to ask about its familiar history for short or tall parents, genetic symptoms such as Down or Turner, or if there is any history of radiotherapy. Physical exam. First of all, we have to measure the vital signs, which can be abnormal in the cardiac cases, Also, we have to measure the height, the weight, head circumference, BMI, HE, ENT, dysmorphic feature, webbed neck, which can be seen in Turner. Cardiovascular system, such as murmur or any dysmorphic features such as Marfan or Turner syndrome. In the respiratory, we have to look at shield chest, which can be seen in Turner syndrome. GI, we have to assess the malnutrition or obesity. GU have to examine the Tanner stage to assess the maturity of or if there is any precocious property. And then you have to examine the nervous system to rule out any CNS lesion, do fundoscopy to rule out papilledema. And the MSK, we have to measure the upper limb to the lower limb to rule out Klinefelter, Marfan. And in the skin, we have to look at hysteria, which can be seen in Cushing, coffee in neurofibromatosis. And the differential diagnosis for the short stature, there is normal growth velocity and abnormal growth velocity. In the first one, there is familial short stature, bone age normal, constitutional delay of the cross bone age will be delayed. However, in the abnormal growth velocity, there is congenital genetic, such as Turner, endocrine, such as growth hormone deficiency, chronic disease, such as cardiac, iatrogenic, such as medication, steroid. On the other hand, tall stature, there is familial or constitutional tall stature. Bone age will be normal or high normal, but not excessive the growth velocity. In the abnormal growth velocity and tall stature, there is endocrine, such as precocious puberty, and genetic syndromes such as Klinefelter, XYY, Marfan. Moving to the investigation, first of all, note that no investigation are warranted in short stature if gross velocity is normal. In the blood work, we have to screen any chronic illness. We have to do CBC, renal, liver function, and endocrine profile. We have to do LH, FSH, GnRH, etc. Imaging, we have to do bone age to differentiate between familial short stature from the constitutional short stature. Also, there is a special test such as karyotype, Turner or Klinefelter. Further workup as needed, such as the antibodies to rule out celiac disease. Finally, MRI for the brain if central precocious property or suspicious of cranial nerve lesion. And the treatment, there is no treatment is required for normal variant, familial short stature or constitutional delay, no treatment. However, the treatment option for the other cases, medical, is underlying disease, such as growth hormone therapy or thyroxine therapy. Recombinant human growth hormone therapy is approved for specific cases such as growth hormone deficiency, Turner, chronic renal insufficiency, and HIV-associated wasting. In the surgical treatment, if there is cancer, so tumor resection is present. And finally, we have to give referral to pediatrics, endocrinology, genetics, gastroenterology, and neurosurgery. Thank you for listening and good luck with your exam.